Good morning, everybody. It's me, Ben Calder here, the Communications Officer for the BTPA, the Bowen Therapy Professional Association. It's nice to see you all again. So I'm back with another one of our interviews with really significant Bowen teachers, mentors, practitioners. And today I'm really excited to be having a conversation with Georgi Ilčev from Sofia in Bulgaria. And Georgi is going to be one of the speakers at the Celebrating Bowen conference that's going to be happening in May in Zagreb this year. You'll find the links for that in the description below. Georgie is going to be talking about the biochemical and kinesiological interrelationship in patients with lumbar disc herniation. And we're going to be talking about that in his interview today. We're going to talk about his quite interesting journey from physiotherapy and manual therapy into Bowen technique and how he struggled with that at first. It's a great story to hear. And Georgie's been a senior BOTEC instructor since 2014. He's also the president of the Bowen Therapy Association of Bulgaria, which is really significant because Bulgaria is one of the few countries other than Australia that has a government-registered training program for Bowen technique that's recognized throughout the whole EU. And Georgie talks through the journey to make that happen and the significance of it. And we talk a lot about his work as well in assessment and how important that is for the body, and how he's worked with a lot of doctors, physios, and other conventional medical practitioners, and how he thinks that we can start evolving more of that with research and good communication within those fields as well. So that's enough from me talking. But before we get to the interview, hit those like and subscribe buttons. Let's help the algorithms push us out there. Let's help more people know about how Bowen technique is a really effective solution for pain and dysfunction within the body, and how we can make the world a better place where we use it. So hit those like and subscribes. That's enough for me. Let's get on with the interview with Georgie. Good morning, Georgie. Thank you very much for joining me all the way from Bulgaria.
Thank you, Ben. Good morning, and thank you for this invitation and for the opportunity provided.
Yeah, no problem at all. Honestly, it's really wonderful for me. I don't think I've actually said in any of our interviews so far, in any of the interviews that I've done, how much I appreciate getting to have time with so many amazing teachers and practitioners within Bowen. It really adds into my knowledge and my understanding. And so I really hope that for the practitioners out there and the people who are listening and learning about Bowen, that you also get an enrichment from the things that we're doing.
Yeah, it's great. It's great to be able to exchange ideas and experience.
Yeah, definitely. I mean, you've been in the world of physical therapy, if we take it as the overall, for over 25 years now. You've got
Right.
a really big career behind you. And I think for a lot of people who've maybe not come across your work before or have only seen small amounts of what you do, I'd love for you to just give us a bit of a history about what you've done and how you got to where you are now. So give us a potted history of your world and how you got to this point.
As you said, I'm a physiotherapist, and I graduated back in 2001. And then I started my PhD program in respect to manual muscle testing. And ever since then, my interest was orthopedics and traumatology. I was mainly interested in back pain, neck pain, shoulder issues, stuff like that. And this is what I've been doing for 10 years starting my professional career. And I've done so many courses, manual courses, physiotherapy courses, to be able to improve my work, to increase my success rate. And I well remember a point when I felt very bored in my clinic because I was sick of back pain, neck pain, and stuff. And I said to myself, I need something different. I need something that will sparkle more interest into what I'm doing, and something new. And then I met Bowen. I shall say that I met Bowen by chance, if there's anything by chance in life. But I was looking for materials on the internet for superficial fascia. And then I saw some YouTube videos on Bowen, which I quickly disregarded. Then I saw some other stuff, which I ignored as well. Because I couldn't understand what is Bowen. There were no explanations, and it's just keep it over. And then I received a phone call by a friend who said to me, have you ever heard of Bowen? And I said, why are you asking? I was in my clinic treating a patient, so couldn't talk much. He said, well, I have a patient who lives in Austria, and she is now in Bulgaria for vacation, and she's looking for a Bowen practitioner for follow-up sessions. And I said, see, I can't talk, but I'll give you a call back. But this made me go back on internet and read more. And again, no explanations, no scientific basis, nothing to explain what Bowen is. It's only Bowen is great. It's helpful for so many issues. It's the best modality, best manual work ever, period. And then I managed to find an email of a BABTT instructor. So I emailed him. He was kind enough to answer my questions and sparkled interest. Then I went to Romania. So my first, my interaction with Bowen was in Bucharest, not in Sofia. There was no Bowen in Sofia, Bulgaria back then. So I had to go to a neighbor country to study. It was a good course. On day 2, I was ready to go home. I said to myself, this is rubbish. This can't be true. Then on day 3, I regret I didn't leave on day 2. Anyway, the course was over. And in my mind, I said to myself, that was quite a waste of time and money. I didn't think that I will ever go back to Bucharest. My instructor said to me, because he could clearly see how pessimistic I was, how many boundaries I had. And so he only said to me, go back home and try what you've learned here. That's all I'm asking. I'll see you in 3 months. I said, you see my back. But it was a month later, honestly, a month later, I couldn't wait to go back to Bucharest for my next course. And that's how my Bowen journey started. And even though I was receiving results, even though I had increased my patients' clientele, I didn't believe that work for a year and a half. For a year and a half, I was so very skeptic. I wasn't believing my own results because I had no explanations. I was lacking scientific basis. I was lacking explanations. And this is what actually made me read more, study more, think more, and then come up with answers to most of the questions I had. Once Bowen started having some logical explanation in my mind, then I was ready to open for that modality and devote my professional life to it. And here I am now. It's been 15 years, more than 15 years since my very first Bowen seminar. And I'm more passionate for that modality than ever. And in my clinic, I treat my patients, 99% of my patients I treat with Bowen only. It's a standalone therapy for me. I have disregarded more than 20 manual modalities that I have learned and practiced in the past. Not because they're bad, they're good. They're effective, but Bowen is better and more effective. I don't need pretty much anything else. Bowen is fine enough for me. And I have a pretty good success rate, I must say. So this is in brief how I met Bowen and how it all started. And in 2014, I was licensed as a BABTT instructor. So then I went on a different level, teaching that modality. And the more I teach it, the more I get deeper and deeper in it. And currently in Bulgaria, Bowen has achieved a significant, let's say, acceptance by the society. It's no longer a treatment of last choice. In some cases, that will be a first choice treatment. And as example, I can say baby colic. If you go on Google in Cyrillic in Bulgarian and write baby colic, there on first page of Google, there will be multiple articles for Bowen for baby colic. So when babies have colic, usually mothers call us as a first choice treatment before they go for any drops, medications and stuff. So it's becoming more and more popular, not only in the medical field, but in the whole society. And this is something that I'm really proud of. because Bowen is now increasing its. I'm missing the word here, but what I'm trying to say, it's increasing its acceptance by the society.
Amazing. I really love that as a story. I don't know if you saw how much that was making me smile there as well. Just to also watch that, like I can see in your face, there's that memory of that disconnect between what you had been taught as a physio and as a manual therapist, and then what Bowen was doing, and it was trying to marry up those two worlds and the
But they're
challenge
so
of
very
that.
different, Ben. They're so very
Yeah,
different. The whole concept of physiotherapy, the university frame of education is so very different from the Bowen framework. And in the beginning, it was very difficult for me to accept that different thinking, different approach. Everything was so very different and difficult. And this is what I see while I'm teaching nowadays. Because when people come to my seminar room, I have medical doctors, I have physios, I have different manual workers, but I also have non-medical background people as well. So it won't be uncommon for people who have no background in any health work, meaning that the basket is fully empty, they get it better and faster than physios and MDs.
Sure.
They simply have the hands. They have the skills, the initial skills that allow them to take that work and somehow to present it. Yes, they do not have the understanding as the MDs and the physios, but they do have the hands, the skills, the manual skills. While the physios, they need to relearn their hands. They need to forget their old habits, which is difficult. It's not easy. And they may not even achieve it at all. Yeah. Some give up. Some give up because the whole framework is so very different. They can't believe it. They used to massage work. They used to pressure, to apply force, to apply a lot of work. It's amount of work. Spend time with the client. No need. That's not the idea of Bowen. Bowen is a therapy of minimalistic work. If only you know where to treat and how to treat, and then leave the body to take care of the rest. So it's not a matter of amount of moves or time spent with the client, or it's only where you need to work and how. How are you going to apply your moves is crucial.
Yeah. So I'm curious as well. When you went on that first Bowen training course over in Romania, you received treatment there, I take it, as well. So you had people working on you. What was that experience like coming from that more rationalistic background?
I well remember that I felt myself quite different. It was quite bizarre observing those Bowen type moves. And then when they were applied on me, I felt almost nothing. And I said, but this is rubbish. I feel nothing. How is ever possible that this can work? But I well remember I was feeling different. I was full of energy. So I was fortunate to be in a very nice group. And there were a couple of ladies quite kind with me because I was the only foreigner. So they would take me out in downtown Bucharest at night. So we spent time in clubs and going to bed at 3 o'clock. At 6:30 in the morning, I was fresh and I couldn't wait for my seminar to start. So I had to walk in the park and kill time, Yeah. And I said to myself, I'm so full of energy. What is going on? It's like I'm on intravenous boosters all of the time. But when I went there for the second course, 3 months later, I was so very sleepy.
Yeah.
My body behaved completely differently. I couldn't wake up. I was so very sleepy. So, I guess it all depends on how the body feels at the moment and what it needs. It will present what it needs.
And did you find that as you went along in each stage of training, that your reflection when you were receiving the treatment, Was that helping your understanding of Bowen at all? Was it adding to the confusion and the kind of the disconnect that you were trying to resolve?
Well, you learn not only by practicing and by observing, but also by, like you said, being a patient yourself, by what you feel yourself. And I well remember that in the beginning, I had almost no body responses. Like, I would say no body responses. I'm not that type of body that will respond, with reactions of kind. Not. But well, remember a story when I was at my module 7 and we were preparing for the examination. And there was one lady in her mid-50s and she had to work on me doing the BRMs. And she was quite, let's say, she was an introverted person, but she was very shy and her moves were very, very gentle. She was afraid to put some pressure or maybe provoke any pain, or I don't know, but her moves was very gentle, like a feather-light touch, almost like doing nothing. And I said to myself, this is rubbish. I don't feel the moves the way I'm used to feel them. This is nothing. It's not going to work. But it did. That was the very first time that my body was full of responses and I was barely able to stay awake. I was forcing myself to stay awake and I couldn't. I fell asleep twice. And at the end, I said to my instructor, she's no good. Her name, I well remember her name. Her name was Viorella. She's no good. She did nothing. And he looked at me strangely and said, no, George, she did very well. That was quite a good treatment for you. I didn't understand it back then. I did understand it later on, years later, when I found out that the amount of pressure we use, the depth, the time of our challenge, the speed of our moves, these are parameters. And when we work on each of these parameters, we apply a completely different input, a different stimulus. So the result will be dependent on the speed, will be dependent on the pressure, will be dependent on the. So by performing different moves according to our body needs and the structure we're treating, we will have a custom-made treatment at the end. And this is something that I cover in my body decoding course, which I teach abroad. This is significantly important. This makes a huge change, and I'm not speaking about Bowen only. This is applicable for any manual work. It doesn't matter whether you do a massage or a physio work or Bowen or whatever. Because this is solid neurophysiology. Those proprioceptive principles are applicable for any manual works, and if you know them, then you'll be able to order the outcome. And your Bowen will be completely different. No manual, no instructor can teach you that work. Only your patients can, because you adapt your move according to that structure current need. At the moment you place your hands on the body, and you will feel the tissues, the skin, then you take slack, and now you know whether you have a normal slack or not. Then you put some pressure for your challenge, and immediately you should know whether that structure, whether that be a muscle or maybe a tendon. At the moment you place your hands on the body and you touch the skin, and then you take slack, you should know whether that structure, not the structure, but the whole area, whether is it normal or not. Because with the time, you have to have a clear idea what is normal for slack. It depends on age, it depends on sex, on gender, it depends on body area. Then you take your slack, then you apply pressure for your challenge, and immediately you should know whether the structure, whether that be a muscle or a tendon or a ligament, is in a normal tonus or not. If it's in a normal tonus, okay, wait a couple of seconds or more and roll over. But if it's not, you may wish to stay longer for a longer challenge. If the muscle is in hypertonus, then you stay for a longer challenge. If a muscle is in hypotonus, then you make a quick flick. You adapt, and no manual can teach you that. And this makes the huge difference between a good experienced Bowen practitioner and a rookie. Because according to the book, this is the same move, the same medial or lateral or whatever move it is. But the way you perform it changes the picture completely.
Yeah. And that's something that only comes with time. The more bodies that come under those fingers, so you can build up that body of experience about what feels hyper or hypotonic, how that tissue is in relation to that person, their response on the couch. It has to be unique for each person rather than a set. We've got guidelines and we've got a framework, but it's just you and that person in that moment. That's what really defines the treatment.
True. And this is where theory and practice meet. Of course, you may have your tactile abilities inherited, or maybe you develop this in time. But if you have the theory behind it, if you know what to look for and how to find it, then your hands will find it much faster.
Yeah.
And you learn.
Yeah.
With every patient, you learn.
So coming from that physio background, did you feel that you already had relatively good palpation skills? And did the nature of doing Bowen work re-educate, re-inform that? Did it change that in some way for you?
Of course it did. My work before Bowen was completely different, and I didn't pay much attention on that tactile ability because I was mainly doing chiropractic work.
Mhm.
That was the basis of my work before Bowen. And now with Bowen, the more time I spent with Bowen, with every year in my practice, the more I pay attention on my tactile ability and what I feel, how the tissues respond, and then adapt and apply my input, my moves where necessary.
Mm.
Of course, I'm not like Tom Bowen. He had amazing tactile abilities, and of course, abilities to know where to treat and how to treat without assessing. I'm not that gifted. I need to assess. Hence, I created this algorithm that I teach in my Module 8 class in Bulgaria and the body decoding course across the globe, which is an algorithm to approach musculoskeletal dysfunctions via different assessments.
Mm.
And that algorithm implements physio assessments, functional assessments, orthopedic assessments, and other information that will guide the practitioner towards the primary dysfunctional site.
Mm.
It may not be even close to the painful area. It may be somewhere quite distant. But the body guides you if only you have the knowledge and the source to pick up the signals.
Yeah, absolutely. Having spoken recently to Romney and interviewed him, listening to him talk about that process and watching Tom and how that's informed his practice, we're all trying to unfold this beautiful mystery that's been left to us in Tom's legacy. And I'm kind of curious as well that when you are working with and teaching with kind of more conventional medical practitioners, doctors, and physios, now that you have the experience and the understanding that you have, how do you decode this for them? How do you draw them from the paradigm that they've been taught to help them understand how we work in Bowen and why it's so effective?
Well, through explanations, through practical demonstrations, because they think, let's easily take back pain as an example. And when you demonstrate that the jaw is influencing the lower back, or the feet are influencing the lower back, or maybe the adductors influencing the lower back, and you demonstrate it because you assess, you have one presentation, then you immediately make a correction somewhere and you reassess. And now you have a different presentation. And now the pelvis is leveled, the spine is straight, the range of movement is improved, the pain is less. Then they say, aha, and this is applicable for everyone.
Yeah.
And unfortunately, in the medical schools, in the physiotherapy schools, the kinesiological aspect of interrelations in the body are not well, it's not, they don't teach it in the medical schools. For physios, they do, but in little aspect. And we have to take into account that this is one whole system.
Mm.
And we're not treating different muscles or different body sites. We treat the whole system. And that system consists of multiple parts, and if one part is not working properly, this affects the rest. And then you're looking for trouble along the lines. If only you know the lines and where to look for these troubles.
Yeah.
Like, for instance, you see a muscle with hypotonus. Many manual practitioners will disregard it. Unfortunately, most manual practitioners, they focus on hypertonus.
Mhm.
They focus on releasing tension here or there. That's not bad. It's okay. It will get a temporary relief. They will get some results. But in most cases, unless there's a direct injury or some overworking, in most cases, hypertonicity somewhere is due to hypotonicity somewhere else. So hypertonicity is secondary, not primary.
Mhm.
So you go and release here or there, and then they will say, I'm better. But in 2 days or 5 days or a week or two, they go back to their previous state.
Mhm.
Because hypertonicity is compensation. If you and I, we need to have a common work. Yeah, we need to do something together. But at some point, I become lazy. I take some hours off. But that work needs to be done, so you overwork. If it's only a day or a week, it's going to be okay. You may say nothing. But in a week or two or a month or two, you will start to complain. I'm not going to complain because I'm fine that way. But you're going to complain. And guess who will get a treatment? You will be treated, Ben. You will be treated with massage, acupuncture, with Bowen, with medications. And every time you get a treatment, you will get a relief. But this is not going to solve the issue unless I start to do my job. Unless I start working my part, you will always overwork yourself and get complaints. So hypotonicity is primary and never disregarded.
Yeah.
So this is something that lacks as knowledge in physios and medical doctors. And this is something that I'm trying to teach all my Bowen students, to think outside that symptomatic box, that medical paradigm of treating symptoms.
I think it's so important. And as you've been speaking about that, actually reminded me going back to first aid training that I had many years ago, where they were talking about an incident where there are multiple casualties. And they said, ignore the ones that are making noise because you know they're alive. It's the people that are not making any noise that need attending to first. And this is the kind of same principle. Look at what's not happening rather than what's, like you say, it's the overcompensation. And too easy to focus on the tightness and think that's the issue rather than understand it's the imbalance, the compensation that we need to be kind of looking where that's coming from rather than listening to the noise, as it were.
I can take that example with the casualties because the hypotonicity are the silent casualties.
Exactly.
They give no symptoms, but
Yeah.
they're the primary source in many cases.
I love that. And, you kind of started to talk in about the kinesiology side of things there, the assessment within kinesiology. How did that first come about within your practice? Was it something that was taught within your physio training or something you added in later? And how are you using it now within Bowen?
Well, when I started working with Bowen, I was told, trust the technique. It was difficult in the beginning. Then I said to myself, okay, I will put more faith in that modality. So I really trusted the technique, but this didn't change my results. No, it increased my success rate. When I got used with the idea that Tom Bowen was a genius, I said to myself, well, George, sorry to say, but you're not a genius. So you have to figure out something because you can't achieve neither his success rate nor the amount of patients he was able to treat. And then I said to myself, I have spent 4 years in my university, then a PhD program, then multiple courses, both in my country and abroad. Why throw it to the garbage? Let's use that previous knowledge and experience and implement it into my Bowen work, not to change my Bowen work, to change the moves or invent new moves or new procedures, more like to understand what the body needs. So focus more on assessment, focus more on case history, on assessment, so that you know where and how to treat. And that was the breakthrough. That was the time when everything changed for me. And that was the time when I started creating this algorithm. Because slowly and gradually, one assessment, another assessment, until I reach to a picture that will tell me where exactly is the problem. Then it's easy. Once you know where the problem is, then you figure out a move or procedure or whatever. You go there and treat it, and it's always going to work. A patient comes to our clinic with back pain. And in the BABTT curriculum, you have so many moves and procedures for back pain. What am I supposed to do today? So let's say today I do kidney, but the week after the patient is no better. So I may do hamstrings, or I may do pelvic work, or maybe knee, or coccyx, or TMJ. It's like shooting in a lottery, week by week, until finally I manage to reach a site that is important and then create a change, and the patient says, oh, I'm better this week. And we're all very happy resolving back pain with 7 or 10 or 12 sessions. This is ridiculous. Back pain you resolve with 1 or 2 sessions just like that. Because all our patients are impatient. They don't have time. They're painful today. And if you don't solve the issue today or in a week, they're very likely to go away. They will find someone else. They don't have time for us to wait to resolve their case for a few weeks or for a few months. So we need to have instant results. And Bowen can provide instant results. Bowen can do that. Only if you know where and how to treat. And this, in my case, I understand by assessing and by asking questions, by assessing, because it doesn't come naturally for me. It doesn't.
Yeah, and so that kind of leads us nicely as well into your talk at the Загреб Celebrating Bowen conference in May. You're going to be looking at the biochemical and kinesiological interrelationships in patients with lumbar disc herniation. So tell us, without giving the game away, because we want to make sure that everybody comes to see you in Zagreb. So what is it that has kind of led you into this approach so much in lumbar disc herniation, and what are you going to be sharing in Zagreb?
Well, most of my clients are with musculoskeletal dysfunctions, and many do come with back pain and lumbar disc herniations. Unfortunately, what I see throughout the years, they have more a psychological trauma than a physical one. Once they do an MRI, and the MRI nowadays is very accessible, so once they do an MRI, a disc herniation is found. Yeah, but that can easily be a normal presentation. Because if 10 of us go to an MRI now, more than half of us will have any discal herniation, but we have no symptoms. So often those discal herniations are just a finding, something collateral. It may not be the reason for their pain. It may not be the reason for their dysfunction. So we assess to find out whether that discal herniation is symptomatic or not. If it's symptomatic, we need to figure out how we can manage the condition. Is there anything that we can do to release the compression so that we improve function and eliminate pain? And here comes my biomechanical and kinesiological, like I've written, interrelations, and my whole concept of approaching patients of that type, where when we initiate specific corrections into the pelvis and the spine, we may be able, it's not 100% certain, we may be able to take the discal hernia back from the nerve root So we release the compression, improving symptoms and function. But again, the whole concept is based on functional assessments and the MRI. When we see how the herniation is situated into the canal, then we know how to approach it. And in most cases, it works well. And I have had many hundreds of patients with lumbar disc herniations that are very significant, huge extrude discal herniations, sometimes with sequestrations, that every neurosurgeon will be willing to operate. And most of these clients have been already recommended a surgery and have been told that if they don't attend a surgery in a week or a few weeks, they may get paralyzed, they will become disabled, and at the end, they have never had a surgery. Often, in 2 or 3 treatments, they avoid surgery. Symptoms decrease. The first thing that we are achieving is decreasing symptoms, but then we need to spend additional work on stabilizing the pelvis, stabilizing the spine, so that we back up the correction from our first treatments. So it can last longer. I'm sorry for my English. I may not be able to express myself the right way.
Oh, you're doing great, Georgie, honestly. And in comparison to my Bulgarian, you're doing splendid. So it's fine.
This we know.
Yeah. So I'm
So
curious as
just to
well.
finish
Yeah,
the topic, what I'm trying to present, what I will be trying to present in Zagreb is my idea of how we can approach patients of that type by using different assessments. And I will demonstrate MRIs. I will demonstrate several cases, MRI images of discal herniations and what have been done for that herniation to get away from the nerve root, so there will be no symptoms. And then we just give the body time to rearrange the soft tissues, to rearrange this fibrotic tissue that is usually the herniation. And in few months, the hernia will be much less. But this is not going to be a spontaneous disc reduction or maybe disc resorption. It's not going to be spontaneous. Now it's going to be inductive reduction. Is this the proper expression?
you tell me what you mean by it.
Induced, I mean.
Yeah, induced.
It's going to be induced, so not inductive. It's going to be induced. Yeah. Sorry, sometimes I'm losing terminology in English.
Yeah, again, don't apologize. You're doing fabulous. I'm curious as well within that. Just in the way that I kind of look at bodies, I think often as the spine a little bit like a bow and arrow, and we see these changes in the nature of the spine. So with the disc herniations, often it's one side, other, front, back. We've got this rotation that's happened somewhere. And I think about the top and the bottom and how that whole kind of system is pulling in on one side of the spine or another, creating that shortening, creating that pressure. I wonder if, and working things like jaw and upper cervicals or, pelvic, coccyx, sacrum, that kind of stuff is really useful in changing those presentations. And I'm curious about your thoughts on that.
My thoughts. See, in the medical school, the spine has been given a huge significance. So everyone is talking about the spine and is treating the spine. But like you said, spine is not primary in most cases. Spine is a victim of changes in both ends of the nervous system. So the cranium, the position of the mandible, the jaw, the sphenoid, the eyes, the tongue, and also the hyoid, these are far more crucial than the spine. Then comes the pelvis and the coccyx, and then comes the feet. And only after that is the spine. And I'm excluding the upper cervical spine. C1, C2, up to C3. I'm excluding this as this is highly important. The rest of the spine is not that important. It's a victim.
Yeah.
Symptoms are there, but in most cases, problems are not there. So we need to look for the cranium or the pelvic girdle or the feet as primary sources for trouble. And depending on whether the patient is ascending or descending, we know where to start. For some, we start with the jaw. For some, we start with the pelvis. For some, we start with the feet. But again, this is solely upon assessment and observation.
And I often see, patients, and you can just look at their footwear, you can look at their feet, you can look at how they walk, and you can see that there's either a causative factor or a compensatory factor going on with the feet. How do you tell the difference when you're looking at that, whether or not the feet are a compensation and a symptom of, or whether or not they're a cause of what's going on further up?
Well, usually when we assess, we don't have one finding. If you only have one finding, then it's easy. But we have multiple findings.
Sure.
And when we have multiple findings, we need to prioritize. You don't follow all the findings because this is a waste of time and work. We need to prioritize. And for some patients, when we prioritize, then we know it's the feet. But again, this is, in my case, I use assessments for this. I use assessments to tell me where to treat today and which is primary and which is secondary. If, for instance, I have an influential jaw, or maybe I have a sacroiliac joint, or maybe I have a deviated coccyx, but then when I perform my assessments, I see that this patient is descending type of patient, then I treat the jaw. If it's ascending, then perhaps I'll treat the coccyx or the sacroiliac. They may have completely same symptoms, but they will be approached differently.
Fabulous. Love it. And I know that, kind of in your history as well, a lot of shoulder and a lot of back pain. Do you often find that resolving these kind of central issues within bodies has that beneficial effect on that peripheral, on those shoulders as well? Or do you find that you often, even once you get kind of like the health, the tonicity back into the spine, that you need to go out and do more specific work on the shoulders?
It depends, Ben. It depends. Again, same like the spine. Shoulder is often a victim. The whole shoulder girdle is often a victim of changes in the cervical spine, the jaw, sometimes the pelvis, and the lower extremities. So what I'm teaching in my body decoding part 2, I'm teaching something that concerns the shoulder and the shoulder girdle. And there I provide assessments that will easily guide the practitioners whether there's any suppressive influence from other body sides towards the shoulder. And if they find such, then they treat these suppressive sides first before they treat the shoulder girdle. How many shoulders you have treated with shoulder work or any local work and they don't respond? They don't, because the primary dysfunctional site is not there. And once you correct the pelvis, the coccyx, the upper cervical neck, and the jaw, you barely have a need to correct anything else in the periphery because it resolves by itself. In most cases, of course, sometimes there is a necessity to treat locally with local work. But start with the central line, arrange the body, restore symmetry, restore function, and then just give the body time to readapt, to rearrange, and if necessary, then treat what's left.
Beautiful.
I believe it was in 2016, I spent half a day in Romney's clinic in Geelong. And then I was asking him a question in respect to those disabled children that Tom was treating every Saturday or once a month on Saturdays. And I said to him, is it true that there were cripples, people on wheelchairs, children on wheelchairs, and after a certain amount of treatment, they will start and walk by themselves. And Ron said, yes. And then I asked him, well, what was Tom doing? Like, how did he approach these children? And Ron said he was barely interested in the periphery. He would assess the coccyx, treat it if necessary, check the neck, swing the neck left to right until he get it right, and then work on the jaw. So this, I guess, answers your question.
Yeah. Yeah, I love that. Thank you. I want to move on as well, because one of the things I know that you're really passionate about, and I think is really relevant as well in Bowen as it develops as a modality throughout the world, is what you've managed to achieve within Bulgaria in terms of how Bowen is recognized by the Bulgarian government. So I'd love for you to just talk a little bit about how that's come about, what you've achieved, and what you feel that means for Bowen as a whole throughout the world.
Oh, thank you for that question, because this is a topic that I'm very passionate about. We spent nearly a decade of trying to find some recognition in our country, and it was very difficult to recognize the Australian diploma, nearly impossible. 3 years ago, in 2023, we created a strategy for accepting Bowen as a profession in Bulgaria. So we applied papers towards the Ministry of Education to be accepted as a profession, and undertook a very difficult path that took about a year and a half, which happened to be quite a short period, but we didn't know it in the beginning. For many people and institutions, when they look at us now, they said, we can't believe you managed this, because no one has ever done it before. The Ministry of Health opposed significantly, and they said we are against any complementary modalities because they're very rigid, very conservative. And they said, if we allow for you to become a profession, others will come and ask for the same. So we have our rejection. Despite that, we managed to achieve it. And after a year and a half, Bowen is now a recognized profession, part of the vocabulary educational system in Bulgaria, with a state standard for Bowen and a diploma that is recognized by the Ministry of, actually issued by the Ministry of Education and recognized nationally, but also eligible in the whole European Union. Apart from this, we created a Bowen Professional College, an institution that will teach this new profession, this new modality. And that Bowen College now has a curriculum of 1,350 hours, which is this now turns Bowen in Bulgaria as the longest and most difficult curriculum worldwide. Into this curriculum, apart from Bowen, we have anatomy, physiology, kinesiology, medical ethics, medical psychology, biomechanics, first aid, and other subjects, and a total of more than 1,300, nearly 1,400 hours. This is 2.5 years. And then you get a diploma with 4 exams, intermediate exams, and 3 intermediate exams, and a 4th exam at the end at module 10, which is the graduation exam. Apart from this, we applied papers to the Ministry of Labor to create a code for this profession. So when you graduate and you get your diploma, you can self-employ yourself or be employed by a company or someone else, and then be assured with that code. So the whole circle is now complete. And this is a great breakthrough for Bowen, because Bowen is no longer a weekend activity now in Bulgaria. It's not just a course. It's a profession. It's a career opportunity for people. And what we have managed to achieve in Bulgaria is not only a local success. First of all, it's a good image for the modality worldwide. But second of all, the rest of the European Union countries can take Bulgaria's example and put papers towards their Ministry of Education, implement our model into their national system, and achieve what we have achieved here much faster and much easier than we did. Because we have this European law that once we have it here as an example and it's working, then we can do the same in this country or other country. So they can take our example quite easily, which is great, because that is, for me, really the best manual modality in the world and the fastest growing modality in the world for the past 40 years. I guess the only competition that Bowen can get is osteopathy, because osteopathy is a vast ocean. And this, for me, is my passion. Bowen is my passion. And it really deserves something better than a weekend activity or just a course performed somewhere. So it's up to us, the instructors, all the schools around the world, the instructors and all the practitioners around the world, to give our best towards Bowen and raise that modality to a higher level. If we don't do it ourselves, no one else will do it for us. Yeah. So we need more reasonable teaching, more scientific research, more analytical, critical practicing of that modality. Not being parrots that performing moves just because we've taught it this way and we just repeat like a parrot, like a monkey. It has to be performed with caution. It has to be performed with our minds. Everything we do has a reason why we're doing it, what we want to achieve with it, and then reassess for us to be able to understand whether we have achieved our initial goal or not. All our treatment should be assessment-led, and then we need reassessment. If we don't work like this, we're lost. Unfortunately, so will be our clients.
Yeah, because we're then condemning them back into a route where they may be going for surgical application when they don't need it, which, you often find that people that have had spinal surgery doesn't necessarily resolve the issue, doesn't necessarily leave them symptom-free, and often can create its own problems.
Because the herniation was not the primary source of dysfunctional pain.
Yeah.
We see it on the MRI, they surgery it, then the patient is still with symptoms, they may even aggravate, and the doctor said, well, go for physio or go for some rehab.
Yeah.
Why didn't you send that patient to a physio or rehab on first place?
Yeah. And so often those MRIs are so limited, they're only looking at that symptomatic point. They're just not taking in that global picture at all.
But do not also forget that the MRI is an examination for structural changes. They are only observing the structural changes. They have no idea about the functional changes in the body. And although I can't claim for objectivity here, but my feeling is like 70% of the problems are functional, not structural. So a patient comes with back pain, in 70% we will see functional issues that we are easily resolving in 1 or 2 sessions. And even though they may have structural as well, if we improve function, this leads to changes in structure with time.
Yeah.
Not every patient we can take out of the surgery table, but most of these clients avoid surgery with our work.
Yeah, which is fabulous. I mean, it's interesting you talk about the function changing structure within the Qigong work that I teach. This is exactly what we're looking at, is how our movement, that internal sense of ourselves, is actually affecting what our body's capable of doing. And so many people are so disconnected from even feeling their bodies and where their center of gravity is, what their balance is, how they are on their feet, how their breathing is. And as you can start to train some of this into people, it's amazing the differences you can get. And of course, we live in a world at the moment where a vast amount of people, and just watching some statistics on this recently, are spending more time than they are sleeping looking at their phones. So one hand gripping this thing, all of that kind of relationship through the neck and the arm, and then they're staring down into this thing that then is affecting the nervous system because of what they're observing. And we wonder why we're getting more problems with necks, backs, shoulders. It's obvious for me.
Function shapes structure. Structure allows function.
Yeah. Yeah. In Qigong, we say that you become the thing you practice the most.
Yeah.
Yeah.
Sure.
So,
Well, if you're constantly on the phone like this, you're looking for trouble because you're
yeah.
not meant to stay like this all day long or sit in a computer for 8 hours, 10 hours, 12 hours.
Yeah. Yeah. I mean, that's why my setup here is a standing desk. So I've had a standing desk for 2 years now. Haven't sat down for 2 years at my desk.
Well, poor me, I've been sitting on a chair for an hour.
Yeah. I mean, I think one of the other things that's incredible about what you have achieved in Bulgaria and the model that gives to the rest of the world is that we're entering into a phase in our world where we know that AI is going to take over a lot of work and people are going to be living very different lives. And one of the things that I'm really keen to look at as the year goes on, and we're going to draw together a number of teachers to do a big panel discussion, is how Bowen is an AI proof career. Because I don't believe that certainly within our lifetimes that AI and robotics will ever replace what our hands are going to be capable of feeling and doing.
Maybe in a few decades.
Yeah.
Maybe. I'm sure that the future of medicine is going to be completely different from what it is today.
Yeah.
I think that in few decades or century, medicine will be like something energetic.
Yeah.
Something that you enter a sphere or something and you'll be rejuvenated all of a sudden somehow or regenerated or I don't know, something like this. I don't envisage it as surgeries and stuff.
Yeah.
Or furthermore medications, chemio, stuff like that.
But I
But
think
who
until that
knows? Who
point,
knows? Who knows what the future brings for us?
yeah, I think until that point, though, you can't replace not only that proprioceptive feedback that we develop as practitioners, but also the relationship that we offer, because we're truly observing people and recognizing what's going on with them as a whole and able to offer them an input that creates change rather than seeing them as an object.
Yeah. Yeah,
Yeah.
I think you're right.
So Georgie, we've been speaking for nearly an hour now. I've got 2 questions left that I want to ask you.
Sure.
The first is, what are we not speaking about enough that we should be in relation to Bowen, bodywork, physical therapy?
What we are not speaking enough. In the teaching process, you mean?
In whatever process you think we need to speak about it more. What are we not talking about enough in the world in relation to Bowen that we need to talk about more?
We are very much discussing our results. We are very prone to, to show off with results, but we don't admit that Bowen lacks diagnostics. It's a great therapeutic tool, but lacks diagnostics. Also, we do not admit that there are no solid medical research for Bowen, which is a huge problem for us because for us to be well accepted and one day this modality to become conventional, we need research. And street talks like, oh, I did it this way and it works, simply serve no good. No one takes this into account. So we need to spend more time on research and we need to put more diagnostics before our treatments so that we have assessment-led treatments rather than just copy and paste treatments. So these are things we need to admit.
How do you think we can get more into the research side of things? What do you think are the blocks to that?
Well, there are different reasons. First of all, the people who practice Bowen mainly are non-medical background people. They do not have that type of thinking. No, they need it. They don't. They're fine with the results they get. They're happy with it. Second of all, creating a research requires a lot of, first for you to know how to do it, to conduct it. then how to arrange it, then to perform it. And I'm not speaking of money here. We don't need much money to create good research.
Mhm.
The Bouen Therapy Association of Bulgaria have already conducted 2 researches in the past with no money. In 2016, we created a research for baby colic. In 2019, we created a research for enuresis, bedwetting. These are all public. Everyone can read this. No money was spent on this research. Now I'm initiating a third one. It will require some financial funding because we need to work with medical labs and some hospitals. When it's done, I'll let you know. But more important is people who are into this field, who know how to perform a research, who know how to create the frame for the research and perform it to a way that it will have less, it won't be that vulnerable at the end. That's what I'm trying to say. Because if a research is very vulnerable, there are some weak spots, then the impact will be much less.
Yeah.
So it's a matter of people who know how to do it. If Bowen was only performed by medical doctors, 40 years later, the picture would have been completely different.
Yeah, sure.
But I think we're fortunate that it's not only performed by medical doctors. Otherwise, they would have abandoned it.
Yeah.
They're much used to work with recipes, pen and paper, than manual work.
And maybe what we need to do is get a GoFundMe set up for research. There's enough of us Bowen practitioners around the world that if we all donated a little bit in, I'm sure that we could help to cover it. Because when there's people such as yourself that have got the skills to be able to put this stuff together, got the frameworks for it, if we can help support that, then it only benefits all of us globally as a whole. So I'm gonna put a shout out to the Bowen community out there. Let's help Georgie fund his research so that we can all benefit from it as well. It's a win-win situation. So I think it's a good direction to go.
Then I thank you for this support.
Yeah, absolutely. It's been great, Georgie, as well. We've been chatting for over an hour now. It's been a wonderful conversation. I really enjoyed it. The last question that I want to ask you is if people want to learn more about you and your work, where should we send them? And we'll put links in the description below.
You mean for the body decoding course?
For whatever you want to promote.
Well, they can always email me on my personal email address and I will respond. In my country, I only teach in Bulgarian. But abroad I teach in English. This body decoding course that I teach for the past nearly a decade is solely based on functional and orthopedic assessments. This is the algorithm that I discussed earlier. And I have been teaching this, I have taught this in nearly 20 countries around the world with some great feedback. This year, I will only teach it in Australia. But next year, there will be more international teaching in Europe. So if any country is interested in introducing or bringing this course, they can contact me directly on Facebook or email, and we can arrange it. It's surely a course that changes the whole interpretation of Bowen.
Brilliant.
It definitely is a game changer.
Yeah, we'll make sure there's links to all of that in the descriptions below. Folks, check them out. And a really big thank you to you as well, Georgie. It's been really nice having this conversation. Really nice to virtually meet you. I'm only sorry that I'm not going to be personally in Zagreb to come and see you there. And I also want to say a big thank you to everybody who's been listening today. Your time and attention is really appreciated. And every moment that we spend promoting Bowen, every moment that you're watching this is helping the world be healthier and to be less in pain and to have less struggle. So the more of that we can do, the better. So you know what to do. Hit those like and subscribe buttons down in the corner there. Share this out to people you know. Let's help the world be a healthier and a more pain-free space. So thank you to everybody listening. Georgie, thank you so much for joining me today.
Thank you, Ben. Thank you for the opportunity. I really enjoyed it. And thank you for our visitors. Thanks.
Brilliant. Thank you so much. Everybody take care. We'll see you again on the BTPA podcast in the near future. Bye for now.
Bye.